Recording has started.
Thank you very much. So yes, again, so what our intention today is, I just want to give a high-level overview of some of the element changes in the 3.5 data set, some of the values, and give a little bit of information on where you can go on the EMSRB website for more information to help you through the transition. There's some checklists and spreadsheets and a lot of other information in there that'll be helpful for your transition for your agencies. First of all, the transition from the current version, which is 3.4 to 3.5, is actually considered a minor update. The system, the elite system, the state elite system is going to have the same look and feel that you've become used to. So there's just a few different things that'll drive you through the process as you do your documentation. The state MNSTAR elite system is available for all agencies in the state to use. And there are some documents on the website, and I'll point those out a little bit later. Like I said, the forms that you'll be using for your patient care documentation have the same look and feel. There have been additional panels that have been added to the form to accommodate more of a top-down approach driven by the new elements. All third-party vendors used by ambulance services have been certified as NEMSIS 3.5 compliant. I have met with all of the vendors except for Beyond Lucid. I think there's one agency in the state that uses them, but all of the vendors have a transition plan and should be reaching out to you. With the exception of ImageTrend, and ImageTrend wants, if ImageTrend is your vendor, they ask that you submit a support ticket telling them that you're interested in the transition to NEMSIS 3.5, and they will start that process. So the board in the end of 2022 set the deadline for all agencies to be transitioned to 3.5 by December 31st of 2023. It's our goal to get everyone there, and any help you need, just reach out to me and I can help make that transition happen, help you through the process. And if you have any questions, just reach out and ask. There's three scenarios for agencies transitioning over to 3.5 in Minnesota. So you either have your own vendor, you are using the state system and using the state provided form, or you have using the state system and are using your own specific agency form. There's checklists on the website that cover each of the scenarios and the specific instances that there are things that you'll need to take care of, and they'll kind of walk you through that process. And again, if you have any questions in any point in that process, I'll show you where those documents are, and you can download those and look through them. And if you have any questions, feel free to reach out to me. So the DIPSAC, Data Policy Standing Advisory Committee, met through the second and third quarter of 2022 to look at all of the new elements and finalized those elements and sent the recommendation to the board for a list of approval at the end of 2022. And in December of 2022, a communication was sent to all ambulance service directors listing the elements that we're going to collect and providing some additional information as well. First quarter of 2023, all vendors used by Minnesota Ambulance Services are NEMSIS compliant, and we're working with NEMSIS to create the data set and schematron that's posted on the NEMSIS website. The Minnesota documents were approved in March, and the first ambulance service in the state of Minnesota was reporting in the 3.5 format as of April 1st of 2023. We have another agency that just came on the middle of June, and they are also one of the larger services in the state, and they started submitting in 3.5 in the middle of June. So what's different? Some elements have been retired and replaced, and some additional ones have been made to add new. And the additions and the replacements are there for clarity, and they actually add better descriptions, and it's more intuitive as you follow down through the documentation. So we'll start by looking at some of the elements that have been replaced. So in the e-arrest sections, so CPR care provided prior to EMS arrival and who provided CPR prior to EMS arrival have been combined into one element, and that's who first initiated CPR. Who used the AED prior to EMS arrival has been actually split into two, and now it's who first applied the AED and who first defibrillated the patient. The chest and lung exam has been actually split out into four elements to describe the location, the assessment, and a chest finding, location, and assessment. The biggest change you're going to see in or that you're going to be aware of in NEMSIS 3.5 are the dispositions. In the past, the incident patient disposition had, I believe, 26 values that you had to choose from, and some of them didn't seem to fit real life situations. That single element has been split into unit disposition, patient evaluation and care, crew disposition, and transport disposition. So I apologize. It was 22 different choices that you had in the past. So now it's been split, and each individual element has fewer choices, and they're either related to patient care, contact, or no contact. The values added to existing elements are better described, and there's also some that have pertinent negatives as well. So the first is the unit disposition, and that the values under unit disposition are patient contact made, canceled on scene, canceled prior to arrival at scene, no patient contact, no patient found, or non-patient incident. So it's very simply, it's like basically, did you have patient contact or were you canceled prior to arrival? In the patient care evaluation element or disposition, you have patient evaluated and care provided, patient evaluated and refused care, patient evaluated, no care required, patient refused evaluation and care, or patient support services provided. So many of them are more, I think they're more intuitive than what past ones have offered you for your documentation in the dispositions. The crew dispositions are initiated and continued primary care, initiated primary care and transferred to another EMS crew, provided care supporting primary EMS crew, assumed primary care from another EMS crew, incident support services provided, including standby, back in service, no care support services required, back in service, care support services refused. This element would be important, especially for those intercepts, and it better describes what happened to your incident if you're transferring the care to another crew. And finally, the last one, transport disposition. And again, this is will be helpful in some of the intercepts because you have transported by this EMS unit, this crew only, transport by this EMS unit with a member of another crew, transport by another EMS unit, transport by another EMS unit with a member of this crew, and patient refused transport, non-patient transport not otherwise listed, and no transport. Type of service requested is another element that has kind of been split out into a little bit different ones, and there's been some additional values that have been added. 911 response, scene, intercept, and mutual aid have been relabeled, if you will, as emergency response primary response area, emergency response intercept, or emergency response mutual aid. Intercept transport value that's currently in the system has been split out to better describe some of those transfers that take place. So it's either hospital to hospital, hospital to a non-hospital, where you might be transporting to a behavioral health facility versus another hospital, non-hospital facility to non-hospital facility. So those would be like maybe a clinic to a clinic or a clinic to dialysis. Non-hospital facility to hospital transfer, that would be like a clinic to a hospital transfer. Medical transport has been relabeled as other routine medical transport. Public assistance not otherwise listed remains the same. Standby remains the same. And the additional values of support services, non-patient care, rescue, extrication has been added. Crew transport only, transport of organs or body parts, mortuary services, mobile integrated healthcare encounter, evaluation for special referral or intake programs, and administrative operations have been added as well. So the unit transport and equipment capability have been, again, some of them have been split and combined. So air transport fixed wing remains the same. Air transport helicopter has remained the same, but ground transport is now split into ground transport ALS equipped, ground transport BLS equipped, ground transport critical care equipped. Non-transport administrative supervisor and non-transport assistance has been combined into one element for non-transport, no medical equipment. And non-transport rescue has been split into two elements, non-transport medical treatment have to move my box here. And non-transport treatment BLS equipped. And the new value of wheelchair, van, ambulette has been added as well. Type of dispatch delay, in addition to the current values that are in there, these three have been added. Communication specialist assignment error, no receiving MD, bed, or hospital, and specialty team delay. Complaint reported by dispatch. Altered mental status, intercept, nausea, and vomiting have been added to that list as well. Patient gender, these three elements have been added to accommodate the non-binary indications. So female to male, transgender male, male to female, transgender female, and neither exclusively male nor female. Pertinent negatives been added to the time of symptom onset. So one of the pertinent negatives is approximate to indicate that the time that you're putting down is just an approximation. And also not able to complete has been added as a pertinent negative in there as well. Other associated symptoms, pertinent negative of symptom not present has been added. And initial patient acuity, the value non-acute or routine has been added. And these would be like, for example, if a patient is being discharged from the hospital and going back to a nursing home, going back to a home by ambulance, that's where non-acute routine would be used. In the injury section, use of occupant safety equipment, the value of unable to determine has been added. That was caused some issues in the past where if the seatbelt was used and the patient was up walking out of the car, you're just not able to determine that value. Types of CPR for documentation. The values for compression hands-only CPR, ventilation with oropharyngeal or nasopharyngeal, and ventilation with an advanced airway device, passive ventilation with oxygen have been added as well. Two values have been added for cardiac rhythm on arrival at department and in vitals for cardiac rhythm electrocardiography for non-STEMI septal ischemia and STEMI septal ischemia. Barriers to patient care. The values alcohol use suspected and drug use suspected have been added to that list as well. In vitals, the ECG type, 2-lead ECG pads or paddles was added. Stroke scale, a number of values, new stroke scales have been added to the list. The Boston Stroke Scale, Los Angeles Motor Score, Los Angeles Pre-Hospital Stroke Screen, Melbourne Ambulance Stroke Screen, Ontario Pre-Hospital Stroke Screen, and the Rapid Arterial Occlusion Evaluation or RACE scale has been added as well. In Extremity, this is a significant one that was more difficult to document in the past, but Extremity assessment, finding location, whole arm and hand left, whole arm and hand right, whole hand left, whole hand right, whole leg left, whole leg right, whole foot left, whole foot right have been added. Under eye assessment, in the past, in the current version, it only allows a numerical value, and now the values for dilated and pinpoint have been added as well. Mental status assessment, there's been a number of additions. Altered mental status unspecified, developmentally impaired, disorientation, unspecified pharmacologically paralyzed, pharmacologically sedated, psychologically impaired, slowness and poor responsiveness, state of emotional shock and stress unspecified, strange and inexplicable behavior, uncooperated and unspecified coma. So these are all values that are not currently in the 3.4 data set. Neurological assessment, status seizure has been added, and other seizures has been added as well. Medication administered, a pertinent negative for order criteria not met. In the case, I'm thinking where this would probably come in is if you're doing an interfacility transfer, you've been ordered to give medication specifically on certain criteria, and that criteria does not occur during the transfer, so you can still document that it was ordered, but the criteria was not met. Administration route for medication, auto-injector, BVM, CPAP, IV pump, nebulizer, umbilical artery catheter, and umbilical venous catheter have been added to the routes as well. Medication administered units, milligrams per hour, had not been in the previous data set, and that was added. In the current data set, the role or type of person administering medication, there were two values for first responder and patient layperson. And in the 3.5 data set, it describes that individual with a little more granularity. So it's fire personnel, non-EMS, law enforcement, or in the situation where it's a patient or layperson, is it a family member, layperson, or a patient? And the same values have been added to procedures as well. In airway device placement, the confirmation method, chest rise, has been added in the new data set as well. Final patient acuity, dead with resuscitation efforts or black, and non-acute routine has been added as values as well. Type of destination, there again, there's been more values that are added. Specifically, the nursing home assisted living facility has been split into 3 individual values that can be chosen rather than just one. And the new values of diagnostic services, dialysis center, drug and or alcohol rehab facility, mental health facility, other recurring care center, and physical rehab facility have been added. Under hospital capability, two things have been done. They've separated out some of the stroke center, so it's not just simply a stroke center. And it also, the element also now has the ability where you can choose more than one capability. And in addition to the strokes being split out, the new values for cancer center and labor and delivery have been added for hospital capabilities as well. And sepsis as a destination team pre-arrival alert or activation have been added to the new data set. So the validation rules, many of them have been modified. They're still based on the dispositions and enforce some of the same constraints. The current data set, none of the national elements have been added. So we did use the national schematron or the validation rules, so they are imported into the system. And it gives us the ability to look at some time constraints a little bit more. There's quite a few values that look at some logic in the times that are documented for your vital signs, your response times, things like that. So the system will give you a flag to tell you that you have to document. If you're documenting a vital sign, it needs to occur after you've arrived at the patient or after you've arrived on scene, which is important because we get, when we're looking at those and specifically the initial values, they're used by trauma teams. They're used by the Department of Health. So there's a lot of information that is important to try to document those as best you can. So if you're using your own image trend system, all Minnesota and national validation rules can be downloaded from the image trend library. And third-party vendors can download those values as well from the NEMSIS website. They are all posted on there. So just a real high overview and as an action list of what you might need to do depending on your circumstances. You'd need to coordinate with any data exchange partners that you have. Make sure that your CAD system can import into your ePCR system based on 3.5 elements. New versions for data exporting, billing, hospital faxing, etc. That everything is good to go there. And any system importing in should deploy all national and Minnesota validation rules to your system. It's already built into the state elite system, so there's nothing you would need to do there if you're using the state system. And keep your demographic information updated on the state site as well. If you don't have or don't remember your login for the state MNSTAR site, reach out to me and I can share that with you as well. But we encourage all services, even if they're importing by third party, to log in, look, see that see if there's any warning messages, failures to import, and make sure that your system matches the number of records that are in the MNSTAR system as well. So update the PCR data entry forms. You need to remove any deprecated elements and add new ones. The easiest way of doing that, especially for the agencies that are using ImageTrend, either the state system or their own vendor, we have a copy of the 3.5 form that is on the in the ImageTrend library. You're free to download that and modify it. We ask that you not remove any of the elements because they are all, it has all of the elements that the state requires. And train your personnel, look at the new data elements and values, the new validation rules. And to be honest with you, the agency that just made the transition, I asked them what training they went through, and they basically said none. They just put it in there. It's fairly intuitive. The changes again, and the elements for disposition seem to make more sense than some of the other 22 values that exist currently. The other thing that'll need to be updated is if you have any analytical reports designed in your system or in ImageTrend on the state site, you'll just need to update those to accommodate the new values. So if you're looking for a specific disposition, you'll just need to change it to the appropriate disposition value. And again, I'm more than happy to help with those as well. And if you have any questions, just reach out to me, and I'll be happy to help you with any building any reports that you might need to. Update the incident list views. Again, this is in the ImageTrend system or in the state system. Sometimes people do build a incident view that looks at a specific disposition, but again, those will have to be accommodated to be for the new values. And if you use the quality assurance module in Elite, you need to update any configuration settings you've created that provide the information for the CQI elements. So let me look at, I'll just give you a kind of a brief overview. This is the 3.5 form that we have created in the for the state use. And again, you can download this form. You can modify it to what works for your agency. Those agencies that are currently using the state system, we do have, this is available. It's in there. And we do have a demo site. And again, just send me an email, reach out, and we're more than happy to share that with you, and you can play with it, do whatever you want to do to get used to the system. So like I said, it's built from a top down. So there's the first disposition you come to is the unit response. And again, everything in the system is driven towards those disposition values. So if you have patient contact made, you see on the left, you have more documentation that you'll need to do, whereas there's not as much required if you do a canceled on scene situation. Patient care, again, these are, the values are pretty intuitive in there. And we will be putting together some frequently asked questions, if you will, on how do I document this or how do I document that, so you can use that in your training as well. And I'll be posting those on the website. So you have the crew and transport dispositions, the transport information, transport modes. So there's some, but again, it's kind of built in a top-down format. So you kind of run into the dispositions, and then there's other dispositions that are required based on those in the validation rules. So many of the validation rules they're built in the same manner and fashion that you've become accustomed to or that you have seen in the past as well. The last thing I want to point out, if you go to our website, ambulance services, and go to MNSTAR, there's a section for MNSTAR 3.5 transition documents. This is a list spreadsheet that has all of the elements. It has the Minnesota core elements for collection, and gives some basic pseudocode on when those cases where the validation rules will be built. The extended data definitions is a great document, and it's a great resource for you to use. And it's put out by NEMSIS, but it covers a lot of scenarios, if you will. So if you go to, here's some of the dispositions, it gives you some situations on when that would be used. So it's a great document that gives a little bit more detail on some of those things, like when would I document this or when would I document that. We have the checklists under here for if you're using the state system and you're created your own agency specific run form. If you're using the state created run form, or if you are using your own vendor. And there's a couple of documents in here that just give a 3.5 transition overview and some common frequently asked questions as well. So I hope that this is meant as a broad overview. Any agency in the state can begin the transition process today if they wanted to. We're bringing on, there's probably the first agency using the state system and the state form is going to be coming on later this month. But realistically, the transition for those agencies that are using the state form is probably going to be the easiest. It's just whatever comfort level your staff will be for using the new form. And it's going to literally drive you through the documentation based on those dispositions. So that is what I have today. And if we have any questions or you can either feel free to put them in the chat or in ask the question. Just raise your hand and we can unmute you. So not hearing any questions, anything you see in hearing anything, Holly? Oh, there we go.
Just a big thank you.
So we do have a question. If I import the 3.5 validation rules, do those contain all previous version rules, or do they build on the 3.4 validation rules? No, the two systems are separate. So the 3.5 and the 3.4 rules will exist, and the 3.5 validation rules will be imported and only applied to those created on a 3.5 form. If you're, Aaron, I think you had mentioned that you're not using or not going to import in 3.4. So you could inactivate all of those and just use 3.5. All right. If there's no other questions, I thank you for your time. I appreciate it. And I hope this was helpful to you. Again, if you have any questions whatsoever, reach out to me. I'll put my email in the chat. And you can also reach out to me by phone as well. All right. At this point, we'll stop the recording and we'll be posting that. If you have, feel free